time for questions at the end in the last 15 minutes. Following the survey, you will receive a brief, following the presentation, you will receive a brief survey, and we appreciate if you would fill that out to help us plan future presentations. And I hope all of you on your screen can see the chat box where you can type questions as we go along. So now I'd like to turn it over to our medical director, Barry Servette, who will introduce our today's speaker. Barry?
Thank you, John, and hi, everybody. And we're all really excited to introduce our speaker for today, who, as you know, is named Dr. Lisa Namerow. And I just want to tell you a little bit about her background. So Lisa is a triple board certified person, which means that she is trained in child psychiatry, pediatrics, and psychiatry. And so she's one of a relatively exclusive group of people who have that unique perspective of really kind of being astride the world of pediatrics and child psychiatry and fully trained in pediatrics. And she actually is the Director of Consultation Liaison at Connecticut Children's Medical Center in Hartford. And she's an assistant professor of both psychiatry and pediatrics at UConn School of Medicine. She went to medical school at UConn and did her triple board training program at Mount Sinai. And she really has vast experience as a teacher and as a consultant to pediatricians for 22 years. She works in our cousin program in Connecticut, cousin to MCPAP, which is a program called Accessmh Mental Health. And that's a really well implemented program that's very in terms of to MCPAP. She's won numerous teaching awards, and she's actually been really engaged with this field of pharmacogenomic testing from an educational perspective for at least 12 years. And she's been teaching and publishing and exploring this field and has presented nationally and internationally to audiences of pediatricians and audiences of child psychiatrists on this topic. And so I'm really excited and looking forward to hearing her presentation. So without further ado, we present that to you, Lisa Namerow.
Well, thanks, Barry. Welcome, everybody. And thank you to John, and thank you to you guys for having started the program way back when, that we were able to finally steal from you back down here in Hartford. I am noticing on my title page that I put the year of 2018. I'm not sure exactly why. We can talk about that later. But this field certainly is an area of interest of mine. At the Institute of Living, we had the good fortune to be chosen back in 2005 as an FDA site to just see if this testing was going to go for FDA approval, which does not mean that the FDA said that it was valid. It just approved the testing as a medical intervention. And so starting in 2005, we were able to send a whole lot of patients down for testing, and often these were patients who had untoward or unusual side effects to medications, and we were finding that their gene results really often did correspond to the kind of side effects that they were having, and that's what started our journey in this field. So I thought that what I would try to do today is take a whole bunch of experience that we have had and distill it down to some take-home points for the pediatricians in the audience, but I absolutely welcome questions along the way, because I'm very used to having a live audience, not a webinar, and I usually can tell from expressions in the audience if I'm on the right track or if people know what I'm talking about or they don't, and because I'm not going to have that interface right now, again, I'd love to hear from you. So my only disclosures is that I did get a quality assurance grant from Hartford Hospital about 4 years ago to take a look at this in our clinical care. and we're just taking a look at those results now, but I'll share a little bit of that with you today. I also, because the women who run our auxiliary store at the hospital also heard about this testing, and they also heard that the insurance companies had pulled back from covering the testing, and they offered a grant for us to test children for free, and so we've just gotten that. And we're going to be able to do more exploratory work in testing that they're going to help fund. But I don't have any commercial conflicts of interest. I don't have any connections to any of the industry companies that are providing this testing, although I will comment a little bit on that kind of testing. But any commercial results that I'm going to review today are just for educational purposes only, and they're not an endorsement of any particular product. All right, so pharmacogenomics really, over the past 5 years, I think, has exploded, particularly because the private industry was able to, again, with the FDA approval that was obtained for a bunch of these chips, really put themselves out there on the market. And they've been doing a lot of detailing. Some of you in the audience may have had some of them to your office. And I think the reason pharmacogenomics is so popular is because we've all really struggled with prescribing medications to patients and them not doing well. So even sometimes when we go low and start slow, we've had patients with unusual or concerning side effects, or patients don't respond to medications that they're supposed to respond to. And there's this whole notion, particularly in psychiatry, although there are a couple other fields who have that as well, but particularly in psychiatry, we're known to do more trial and error prescribing, and oftentimes that doesn't feel so good. But the caveat, and one of the biggest take-home points, is that we really do need to be careful and understand what pharmacogenomics can and cannot yet do. So that's what I'm hoping to do. Back in 2001, there was a New England Journal of Medicine article in which they took a look at pharmacogenomics was just starting, and there was a hope that by 2020, it would really be a standard of practice. That wouldn't it be great if we could predict who was going to have side effects? And here we are in 2017, almost 2018, and it really is not yet a standard of practice. And in part, that's because and there's been a bunch of editorials about this lately, that the data has been mixed as to really how helpful particularly if you apply some of the entire panels, which have up to 7 or 8 genes all put together at once, whether or not these panels truly help in a way that's statistically significant from just usual practice. So the journey is still out, and that's why there's been a bunch of editorials lately that say, hold on, guys, this is not yet proven. Let's sit tight. But so where do we begin when we want to try to understand this? To me, it's sort of just let's start at the beginning. So again, as I said, the hope of pharmacogenomics was, and this diagram, hopefully you guys can see this arrow, but the diagram is just to kind of show that really we can have a bunch of patients with the same diagnosis who's given the exact same prescription, and some will have a toxic side effect and the drug won't be beneficial at all. Some will not have any toxicity and the medication will be beneficial. Some will have some toxicity and the medication is not beneficial. And then this group is often the toughest, where we have patients that come to us who have some side effects, but actually the medication has been beneficial. So, you know, how do we understand what's happening with these 4 groups of patients? And again, the hope of pharmacogenomics was to minimize the potential of the side effects and maximize the probability for the drug that was to be, that the drug we choose would be effective. All right, so what's the basis for the testing? There's a whole science behind this, and it's in the realm of molecular biology. And following the completion of the Human Genome Project, it really was determined in very scientific ways where genes might have problems in them, and then whether those problems might produce a protein that is going to be deficient in some way. And that's a whole lot of bench research that's been accumulated and stored. And so in the field of psychopharmacogenomics, what we're looking at are genes that code for the enzymes that metabolize medication, and we're also looking at the genes that have to do with the site of action of the medications, and I'm going to go back to that. But the testing is going to tell us whether or not our patients have in their genes that we're looking at have any polymorphisms that then are going to cause alleles that then impact the actual product that that gene is going to produce. And those alterations might impact the activity of the enzyme that we're looking at, or they might change the molecules that are the target sites of the medication. So that's the receptors or the transporter genes. So the fact that those alleles exist and the fact that they've been identified, that's not where the debate is. The debate is whether or not, based on those gene findings, how much we're actually going to be able to impact treatment outcome. And it turns out that that is a lot more difficult in a research design than I ever thought. I included this slide and I can give you guys websites, but these organizations are basically the think tanks of this field of medicine, which is, there's a think tank called PharmVar, and they're the ones that store any of the information about the alleles that results in problems for multiple genes, lots and lots of genes. And this is the organization that either says, yes, that allele is a problem, or no, that allele is not going to be a problem. So the field of pharmacogenomics really relies a lot on the data that PharmVar has collected. PharmGKB, which is another think tank, is combined with CIPIC, which is another think tank, and they are trying to come up with objective recommendations for what to do with the gene findings that we get back when we get this testing. And so they both serve as resources for those of us that are trying to figure this stuff out and are trying to figure out how to best apply the pharmacogenomic test results that we get. So as I said a little bit about before, where are genes playing a role in pharmacotherapy? And again, it's two categories of genes. One category are called the PK genes. They are the pharmacokinetic genes, and they are the genes that code for the enzymes that metabolize the medicines that we're prescribing. And then we have the PD genes that have been identified, and those are the pharmacodynamic genes. Those are the ones that code for the targets. So for instance, serotonin reuptake inhibitors work at the level of the serotonin transporter gene. So the serotonin transporter gene has been studied significantly in terms of whether or not problems in that gene might result in problems responding to SSRIs. And I'll talk a little bit about that. So this diagram, again, just shows that here is where we have genetically susceptible factors from drug administration to the clinical effects. And it's in the area of what's going to determine the biological fluid concentration, and those are the way the medicine is metabolized. And then there's the PD genes, and that's really what happens to the level of the brain when the concentration of medication is enough that it crosses the blood-brain barrier and gets to wherever it's supposed to be, causing its impact. So the PK genes that are the most studied and the ones that you will see the most often if you have seen or ordered this testing, and I've listed really the top four. And these are all genes that code for enzymes that are within the P450 system. And it turns out that in the world of psychotropic medication, most psychotropic meds, but not all, which is also really important to know, are metabolized somewhere within the P450 system and are coded for by the genes that I have listed here. So whether that's the CYP, the CYP, that stands for cytochrome P450, the number has to do with the family that the gene is in, and so these are not only the names of the enzymes themselves, but the name of the gene that then codes for that enzyme. The PK genes are less impacting in the other ways that medications are metabolized, in either conjugation or in just renal excretion. So predominantly when we talk about the PK genes that we get back, we are looking at the PK genes that code for the enzymes that are within the cytochrome P450 system. And again, this is just to give you a little bit about, what this term, what CYP2D6 even means, and it references the cytochrome P450 system. Then the genetic family is number 2, the genetic subfamily, and then that's the specific gene. The reason I highlight CYP2D6 is that CYP2D6 is actually one of the most common and utilized enzymes within the P450 system. And so it is the one that has been the most studied when it comes to pharmacogenomics. So when there are problems within the PK genes, how do they alter the proteins that they produce? And again, you guys may have seen this either by having ordered this testing already yourself or having families bring the testing into you. But basically, the problems in these genes either end up creating enzymes that have poor or no activity, creating enzymes that have deficient activity, and in some of the labs that are out there, they call the deficient activity phenotype intermediate, which doesn't make that much sense to me. Or it's creating enzymes that have normal activity, and again, the term that has been used out there by other labs is extensive. So again, that doesn't necessarily bring to mind normal activity, but I wanted you to know that that term's out there. Or these allelic variants might create enzymes that have ultra-rapid activity. And that's, again, that's all been laboratory documented. The relevant PD genes, as I said, serotonin transporter gene is probably the most well-studied. Serotonin receptor gene, the norepinephrine transporter gene, there are just a couple studies out about that, and that would be more for the antidepressants that target the norepinephrine rather than serotonin. In the ADHD world, the genes that have been most looked at is either COMT, one of the enzymes that's in the dopamine pathway itself, or looking at the actual adrenergic receptor gene. And this is just a little bit about the serotonin transporter gene because, again, this is a PD gene that really has a lot of data about it. And again, as I said, this is the gene that codes for the uptake mechanism for serotonin. So serotonin is released, and the serotonin transporter enzyme picks it back up again and puts it back in the presynaptic vesicles. And SSRIs actually block the activity of the serotonin transporter, allowing for more serotonin to stay in the synapse. And so it would make sense that if there were problems in this transporter protein itself, that then there could be problems with whether or not the SSRIs are going to work. To make this stuff a little bit more complicated, the polymorphisms, and that's the problem within the gene, gets its own label. And this is the polymorphism that's been most studied in the serotonin transporter gene world. And it creates two different allele versions, either something called the long form or something called the short form. And again, I list this in these slides because many of the industry results, the lab results that will come back to you will actually specify to you what the actual gene findings are, so it's good to understand the terminology, but it's the short form of this polymorphism that results in the problem in terms of response to SSRIs. The long form is what's called the wild type. That's what you want, and the long form allows for better response to SSRIs. The serotonin receptor gene is also, as you would imagine, plays a role in one's response to SSRIs. And so it's been also studied in terms of might problems with this gene result in problems with the way we respond to SSRIs. And these are the genotypes. They're just single nucleotide polymorphisms. They just replace one for the other, and those can result in genotypes that produce proteins that are a problem. But as you can see here, where gene studies start to get complicated is that sometimes these gene findings are more robust in one ethnicity than in the other, and this particular one is more robust in Caucasians than in Asians. And therein, again, starts to lie the complexity of trying to extrapolate some of these findings to a population in general. In the ADHD world, a gene that's been highly studied is COMT because it degrades dopamine, and it is the MET genotype, which is, again, a result that you will get back if you order this testing. And the caution is that if an individual has a MET genotype, then they may not do as well with the dopamine agents such as Ritalin. And that's how the result will come back to you. The alpha-2A adrenergic receptor has also been looked at in terms of ADHD and Ritalin treatment, and it looks like this particular problem in the adrenergic receptor gene might yield a reduced response of methylphenidate, whereas the G allele had better or more significant improvement in the inattentive symptoms of ADHD. So here's the issue. So it sounds wonderful, and so do genes tell the whole story in terms of medication metabolism and efficacy? And the answer is no, and therein lies part of the problem. So first of all, we know that when it comes to anybody's response to medication, there are non-genetic factors involved. So whether that be an individual's liver function, renal function, their age, their height, whether they're being compliant with the medication, whether they're using alcohol, tobacco, drinking grapefruit juice, which alters for some medication the pH enough to alter absorption, or whether or not they're on other medications which by themselves inhibit or induce enzyme activity and therefore might be causing some of the problems that we're seeing. And there's also what we call the epigenetic factors, which is that just because you have a problem in your gene doesn't mean that your gene will produce an outcome that's a problem. And we know, I like to use the BRCA2 analogy, that even though an individual could have homozygous for BRCA2, it doesn't necessarily mean that you are going to get breast cancer. It just means that as a result of having a problem, the BRCA2 gene, then your vulnerability has increased over the general population. So this model works in terms of my understanding of where pharmacogenomic testing can be helpful, but we have to understand that it's about conferring vulnerability rather than predicting 100% outcome, and that's where we have to be careful. So what do the results look like that you might obtain, and how do you best apply these results? And most commercially available gene panels are categorized by disorder. So some of you may have had the experience of seeing a grouping of gene results, and they call it their ADHD panel, or the depression panel, or the pain panel. And the report's going to contain specifics on which gene are being tested, what's the finding for each gene, and then what's the possible clinical implication. And then the relevant medications will be listed in terms of green, yellow, or red based on what the companies have as an internal algorithm. They've put together their own determination of how much each of those genes are going to contribute to that overall sorting of red, yellow, and green. So again, you want to remember the genes tell you more about vulnerability and possible risk, but not absolute. And that's, again, to me, what families really need to understand. So here's a case, 12-year-old male with symptoms of ADHD, currently in 6th grade. The diagnosis is well supported. There is a 504 plan in place. No other stressors are noted, but the symptoms are continuing to significantly interfere with school performance and self-esteem. And this patient is coming already having had 2 appropriate medication trials, but significant side effects. So to Vyvanse, irritability, insomnia, and anxiety, and to Atomoxetine, headache, fatigue, palpitations, tremors, and dizziness. And so in this case, before the physician proceeded with further pharmacotherapy, they did get the testing results. And as I shared with you for this particular company, these are the genes that are done on their ADHD panel, and there certainly is data to support the consideration of these genes in the treatment of ADHD. So they looked at COMT, they looked at the adrenergic receptor 2A, and 2D6, since 2D6 is the enzyme that plays the most significant role in ADHD medications. And so the results were okay in terms of COMT. So they will, the interpretation is that they will have a typical response to stimulant medication. And over here, in terms of the alpha-2A receptor, the GG confers that there is no vulnerability within that gene. However, in 2D6, there is a star 17 allele, which does lead to reduced activity. And so this individual will be more vulnerable when it comes to medications that are metabolized by 2D6. And so that's what they're providing to you, that these medications are more green because dexmethylphenidate is not metabolized primarily by 2D6, neither is guanfacine. But over here in terms of the amphetamines, they are metabolized by 2D6 and so are in the warning category. And Atomoxetine, which is among the most significantly associated medications we have in psychiatry with the PK genes, because it is a sole substrate to 2D6. So Atomoxetine, when you have a 2D6 issue, there is high vulnerability for side effects, enough that the FDA has actually put in the package insert for Atomoxetine that difficulties with the 2D6 may lead to side effects, and therefore dosing should be reduced accordingly. So this patient was ultimately put on methylphenidate and had good effects. following floor plan was in place, and this patient, who was a patient of a colleague of mine, did well. This is what the insert looks like. For Atomoxetine, and again, it is among the few medications where PK gene findings and recommendations have actually made it to the FDA labeling, in which they talk about if you're on a medication that's either going to inhibit 2D6 or you are a 2D6 poor metabolizer, this is how you should modify the dose. Here's case 2, 15-year-old who presents with a 6-month history and gradual worsening of the following symptoms: worry, depressed mood, poor motivation, poor sleep, energy concentration, and because the family was very concerned about any medication, for this case, my colleague actually ordered the genomic testing prior to even starting any medication. Here were the genes that were looked at. Again, both the PK genes, and because antidepressants are metabolized by genes that are throughout the P450 system, there were multiple PK genes looked at. And for the most part, this individual had minimal vulnerabilities. There was some vulnerability with 2B6, which is not a particularly active or important P450 enzyme, and in 2C9. In the pharmacodynamic genes, they looked at the serotonin transporter gene, which looked okay, and the serotonin receptor gene, which looked okay, and HLA, which really has mostly to do with toxic epidermal necrolysis, and Tegretol was listed as well, or was tested for as well. And so this patient had a whole lot of green medications to choose from, at least according to that testing, and this individual tolerated the trials quite well, but in fact didn't do well in terms of the depression and anxiety symptoms. And this case just points out that even if your gene profile looks pretty clean with minimal vulnerabilities, if you're not following through with other recommendations in the biopsychosocial treatment plan, such as individual therapy or in-home services or extra help within school, there can be a lack of efficacy from those factors alone. So how do the labs know which enzyme metabolizes which medication? That, again, has been an FDA requirement for a long time, that any medication that comes to market, it has to be reported what enzyme breaks them down. And there is, in fact, out, again, in the public domain, the Flockhart chart done many years ago that summarizes the existing medications and then what enzyme pathways metabolize which medication. And here is something to really watch for, because many of the companies, although they will give you the gene results and they give you the medications in terms of red, yellow, and green, they do not necessarily list for you the medication in terms of which enzyme actually metabolizes them. And so here at the Institute of Living, as we've been doing our research, and we've used a lab here at Harvard Hospital, and we always had access to be able to verify, okay, if there was a problem with 2B6, and I see that that makes Strattera in the yellow or the red, does 2D6 have anything to do with Strattera? And we were able to kind of cross-check and make sure that, in fact, the enzymes that are being reported really have something to do with the medications that are being listed. The medication that actually one has to be the most careful about, because this pops up a lot, is that a medication called Pristiq or venlafaxine is not metabolized by any of the enzymes that are often looked at in terms of these panels, and so that leaves Pristiq in the green category very often. And again, without knowing that Critique isn't actually metabolized by the enzymes that the gene testing was looking at, you wouldn't know that, well, okay, Critique looks green because none of those, it's not having a problem with any of the genes, but that in fact could be that the gene that metabolizes Critique isn't even being looked at. So this is where one needs to be a bit careful about how some of the results are reported back. So I hope I haven't sent you guys all running in the other direction. So when or should a pediatrician order this testing? And again, for me, it does depend in part with your comfort on the interpretation. It is not a standard of care. But families may bring the testing to you, and it does certainly look like over the next decade there'll be more and more research about the validity and applicability of pharmacogenomics. Our research so far has taught us that the testing is most relevant when you have a patient who has a history of significant or unusual side effects, and you're trying to understand why the standard therapies, based on the evidence-based medicine that we have, are not working, or why an individual has not tolerated the medications that you prescribed. So you want to be discerning, and you really want to know what you're ordering. You want to know what panels include which genes. You want to know that the results that you're getting is a combination of the results of the genes that have been tested for. You want to keep in mind that the PK genes are most likely going to determine or help determine vulnerability around tolerance, whereas the PD genes are going to tell you a bit about the potential for response or efficacy. And even though the results might be conveyed back to you in terms of green, yellow, red, you still want to consider looking at each gene result individually, and that's quite honestly how we've learned what we know here at the IOL. And keep in your mind the concept of vulnerability. Remember that genetic contributions to medication tolerance are about 42%, and it's the other factors that then have to really additionally contribute to outcome. You might consider the following script. This testing does not tell me which medication your child will respond to, but it may, in conjunction with evidence-based recommendations, help me select a medication that reduces the chance of untoward side effects and increases the chance of response. Additionally, there are a bunch of pediatric medications that a child often has already been exposed to that might help you determine whether somebody might have 2D6 problems. And we've kind of come up with, and a medical student that we're working on is going to take a look at this in terms of these questions in terms of sensitivity and specificity. But just as a quick recommendation, not only do you want to ask your patient before you prescribe medication, have they ever had side effects to psychiatric medications, or has anybody in the family, but you also might want to probe a little further, because lots of the medications that are used in the pediatric world, often against pediatrician recommendations, like cough or cold medications that are just over the counter, dextromethorphan, pseudoephedrine, they are also metabolized by 2D6 and can serve as almost an exposure test. Because if you have a patient who already has had one of those unusual but very significant reactions to cough or cold medication, that may already indicate that there could be a problem with at least the 2D6 enzyme. And the same for pain medication. Codeine is primarily a 2D6 substrate. Codeine requires 2D6 to break down to morphine, which is the active pain compound. And so in individuals who have had already a problem with codeine, either not responding or getting sick or becoming somnolent on a tiny dose, that all might suggest, again, a little window that we already have a vulnerability, at least within the 2D6 gene. So there's certainly lots to learn and consider. There will be much more published on this. There is an expense, and it certainly does not suggest that everyone should be testing. But again, our experience suggests to us that in individuals with a history of significant side effects, pharmacogenomic testing may play a role. But the challenge for all of us prescribers is to know enough about the testing to be able to best apply the results, and also to be able to best set up our patients and our families for what the results are going to tell us. So I think I am going to end there, and I'm hoping for lots of questions, comments, and thoughts. Thanks, everyone.
Thank you, Lisa. I have a couple questions here. What about, I know you'll probably answer this from Connecticut's point of view, but what about insurance paying for testing?
Right, so the industry is really working on that. There are certain companies that actually are either promoting free testing or sliding scale testing. So it ends up being individual to the company that you might use, but it can be worth contacting them to find out. In Connecticut, ironically, our Medicaid, our Husky program, is covering the testing, and the commercial insurers are not. Now, the caveat to that is that there are some gene medication linkages in the medical world, like Coumadin and 2C9, and so 2C9 is sometimes covered and 2D6 is sometimes covered, but the entire panel is often not.
We have a question about what is the approximate cost of some of the testing?
Yeah, so again, some of the companies have reduced the dose to about $400. So it's not thousands.
Thank you.
Or somewhere between $450 and $500.
Question, is there actually any study that shows how uniform testing would help or not help?
Yeah, that's a great question. I'll quickly tell you about our study. So 3 years ago, we got this grant, and we had embedded in our outpatient practice a clinical coordinator that was doing a bunch of standardized testing to help us with diagnosis. So we had a bunch of data collected on patients who came for treatment of depression, and we're just getting treatment as usual. So we used that cohort as our retrospective cohort, and we did a prospective cohort where any patients who came in for treatment of depression, before we did anything, we would get just the PK genes. That's primarily what we've been looking at here, and we've used that for guidance, and we wouldn't prescribe medication unless. And so we did 100 retrospective, 100 prospective, and we used medication, whether or not a patient was still on medication at a 4-month mark, as to whether or not we had selected appropriately. And then we took a look at some other depression results. So in our study, both cohort of patients got better. And they both got better in terms of the depression scores. There was no significant difference, and there was no significant difference in terms of whether or not the patients were on Medicaid. We had about a 20% discontinuation rate, which was actually low. It's usually about 35 to 40. So we think that we didn't see any difference. When we took out the patients who had 2D6 vulnerabilities, they actually did better than we would have expected. And I'd have to show you some of the graphs. But this is part of why we began to see that it was really the patient with the vulnerability that was going to do better with testing than just the general population as a whole. So at least that's what our study also showed, that in the guided cohort, we prescribed more placebo. And that was the one that made us pause and say, hold on here. you know, Prosteq is not the first line of medication in the world of depression, and we were using it because it was green, and honestly it took us a little while, I mean it took us in the retrospective analysis to say, whoa, wait a second, we got to be careful here, not all green medications are green because the gene that metabolizes them is good, it's because we're not even testing for the gene that metabolizes them. So that's where things get a little bit tricky sometimes by just going for the green, yellow, red. So that's kind of, I will also tell you though, the industry studies, and this is where all the editorials went wild, is that there's industry-supported studies that do say that if you did a cohort of patients with panel guidance, that their depression scores got better than patients who were treated with usual. That type of study has not been repeated in a non-industry setting. And so that's where, at least on the psychiatry side, there's been so many negative editorials.
Thank you. If you do want to do testing, how do you decide about what company or who should do the testing?
So I will say that the companies are all using the same allelic data, and they are all using the same, you know, basis for the conclusions that they're drawing. So when they say Val makes you more at risk with Ritalin, that is out there, and that is what the studies are showing. So they are all using that. Where they're differing is which genes they're including. So as I showed you that depression panel from one company, they've really expanded their PK genes into genes that code for enzymes that aren't even that significant in the depression world. So that's where things are different. So what I would say is, you know, I'm sure Genemind is up there in Massachusetts. I don't know, for those of you who have had experience, which company. But to me, it's not so much the company, it's that we all as the physician who's ordering the test know enough to really be able to use the information in the best way we can.
Thank you. Another question is, given that different medications have these different enzymes, what would you predict? Would you predict any particular medicine to start with based on the probability of of how that medication might work? You know,
yeah, so that's
Zoloft versus Alexa.
Yeah, so here's where it gets interesting. Like, so the more you do this, the more you can begin to internalize. Like, okay, so there are 6 SSRIs. There's Zoloft, there's sertraline, fluoxetine, escitalopram, citalopram, and what am I missing? And each of those SSRIs are metabolized by different enzymes. So for instance, escitalopram and citalopram are predominantly 2C19. Prozac is predominantly 2B6. So sertraline has some 2C9 and 2B6. So even knowing that information, and I think this is what happened in our study, because we've had the testing for over a decade now, lots of the child psychiatrists in my group know this already. So if a patient already came to you having a side effect of sertraline, then you would say to yourself, geez, I better get out of the 2C9, 2B6 category altogether. Let me switch over to an SSRI that's metabolized by a different enzyme. So you can do some of this work kind of just on your own, just based on the side effect information that you already get from your patients. And I did try I couldn't upload it onto a slide for you guys today, but I'd be happy to share with you at least the Flockhart chart that has to do with the antidepressants, because it's a really good thing to just have on your desk. And again, if your patient, and I don't know, how many of you are old enough to remember when Atomoxetine came out, but there was so much hype, this was going to be a great medication, this was, again, before it was really known what a sole substrate it was for 2D6, and I remember having a patient that I gave 10 milligrams to, and it put her to sleep for 24 hours. And so let's just say you had that unfortunate occurrence. You would really pretty much know that this patient has a problem with 2D6. It has to be. And so I better not use any medication, you know, now if I'm going to go further along, I better not use a 2D6 medication. And I also will tell you that from our academy meetings recently, because Atomoxetine often has had like a biphasic response, like there are patients that do great on it, patients that do horrible, they are finally taking a look at those patients' gene profiles. So again, I think we're going to know more. It's really taken a while for, I think, psychiatry, particularly child and adolescent psychiatry, to kind of at least get on enough with saying, we got to really be looking at this and not necessarily let the industry get ahead of us.
So folks would really like that. Folks would really like to have that chart, Lisa, if you could do that for us.
Okay, I'm going to send it as a PDF because I could not copy the PDF onto the slide, but I'm happy to send it.
That's great. But again, just to reiterate, so you say that once a medication is you had a poor response to a medication, it might influence what you choose next. Do you use anything in order to choose the initial one? For example,
and that's, again,
that would start with Prozac. Is there any reason not to?
So here's an interesting thing we found out about Prozac. So in our retrospective group, we also had data on, you know, which meds we used and which meds were the best tolerated. So Prozac's complicated because Prozac is both metabolized by 2D6, but also further inhibits it. So it gets a little complicated. And so in the enzyme world, it is a little more messy than, let's say, citalopram or escitalopram. So I might, and again, this is not going with FDA approval, this is going more with the PK information. I personally tend to start with the medicines that are a little less complicated in terms of the pharmacokinetic metabolism stuff. But this was interesting. In patients in the guided group, in patients where we used Prozac because it was green, at the end of the 4 months, we had 100% tolerance. So patients who were started on it were on it at 4 months. In the retrospective group without guidance, it was the usual 60 to 65% were on it at 4 months, and 35% were not.
Okay, thank you. I think this ends all the questions we have. Lisa, I'd like to thank you very much for your presentation. Barry, any follow-up comment?
No, actually, I thought that the questions were really good, and I actually thought the presentation was extremely useful and practical for actually it's going to influence my clinical practice in some ways as well. So it's really fantastic to have the update about this and to, because it's a field that's really rapidly evolving, and so it's really nice to get the latest update as far as how to think about this testing.
Yeah, I think if I might close for one more thing, keep your eyes on the serotonin transporter gene. I frankly find that super interesting because that particular gene has also been implicated in the resilience world, in the trauma world. So it really looks like it's a big ticket item. And again, it may begin to shift us. You know, we in child psychiatry have a whole lot of, you know, our evidence-based medicine tells us SSRIs, and I still believe that SSRIs are the first choice for sure. But we might go away from the SSRIs, you know, for the second trial rather than waiting for 2 or 3 SSRI trials before we go to, NRIs or NSRIs. So I, in particular, am watching that serotonin transporter gene pretty carefully.
We're actually in the process of developing clinical practice guidelines for MCPAP to try to align all the recommendations that we give, and for basic issues around depression, ADHD, anxiety disorder care, and also to sort of organize our minds around the teaching that we provide to PCPs, and I think we're going to incorporate some of this material into the guidelines. I think it'll be important. So,
absolutely. Yeah, and this is where I want us, our academies, Pediatrics, Child Psychiatry, to take back hold, because yes, we understand that you can get some of this information just by going low and going slow for sure, but if we just stay with that, the industry is going to get ahead of us, and honestly it has. That's why they're doing the detailing, and at our academy meetings there are less discussions about it. So we need more discussions so we can take the field back.
Okay, I've noticed the time, so I want to thank Lisa and Barry, and hope everyone has a good holiday. Reminder that we will not have a discussion, we will not have a clinical conversation in December, so our next one will be in January, and you will get a notice of that. Thank you, everyone, for attending, and have a great holiday. Bye now.
Bye-bye.